Hi, my name is Paul Latkany. Vision and eye-related injuries are obviously very important. The name of our application is Frodontal, inspired by Frodo's focused journey through darker elements. Just as ontologies in ocular trauma provide clarity in the murk that is the medical record. Ocular trauma is very common. In the year 2001, over 2 million people in the United States sought medical attention for an eye-related injury in the United States. The eye is a very delicate organ, not designed to recover from any severe trauma. The surgical and medical techniques also have not improved in the past couple of decades. Prevention has been demonstrated to reduce the severity of eye trauma and improve outcome. Do the symbols on a medical record accurately convey the details of an eye injury? As we've learned in class, it's definitely no, but it's what we have. Retinal detachment, endophthalmitis, globe rupture, globe perforation, and afferent pupillary defect have all been identified as important prognostic factors in an ocular trauma score. The most mature scoring system is in fact called the ocular trauma score, and it's based on the presence or absence of 5 clinical signs, including the initial visual acuity. It predicts the likelihood of a particular range of visual acuities at 6 months at the time of onset of the injury, and it's usually documented by an ophthalmologist. Here's how to calculate an ocular trauma score. Patient comes in, you obtain their vision. Let's take a situation where someone comes in and they have a vision of light perception to hand motions. As you can see on the upper right, they would get a score of 70. If the only other finding is that they had an afferent pupillary defect, you would subtract 10 on the lower right from that to give them a total score of 60. On the upper left, you could see they would have an ocular trauma score of 2. And as you could see the probabilities across the chart on the second row, they would have more than a 1 in 4 chance of being completely blind in the injured eye. Why is the ocular trauma score important? It's a very difficult discussion with a patient who has recently suffered severe eye trauma. Heightened with that is that there's a risk of sympathetic ophthalmia, which is rare, but can involve the opposite uninvolved eye in a way that risks include blindness. The only way to avoid this rare disease is to remove the eye within the first 2 weeks after injury. The ocular trauma score gives the likelihood vision will persist. The problem is that there are multiple values and multiple taxonomies and ontologies that need to be utilized to correctly and ably populate an ocular trauma score algorithm. In the setting of trauma, there is an urgency in taking care of the patient that oftentimes does not permit careful documentation. Here is an example of the many terms that exist within ICD-9 and ICD-10 for just one of the data elements, endophthalmitis. In addition, visual acuity is recorded differently in different parts of the world. For instance, on the upper left, we see in the US, visual acuity is 20/20, but in Europe, it would be recorded as 6/6. And in other parts of the world, there are other measures.
Hi, my name is Andrew Walz, and I'll be presenting on the remainder of the presentation. As you can see here, this is a development of an ontology that we utilize to facilitate correlation of the injury and visual acuity data into the ocular trauma scoring system calculation. As you can see here, the ontology begins with a clinical case, of which we create many instances in the program. Each clinical case is associated with an ocular trauma score, and an ocular trauma score is comprised of an injury and a visual acuity. Injuries can be either open globe or closed globe, and specific instances of these injuries in the ocular trauma ontology are rupture, perforating injury, endophthalmitis, retinal detachment, and afferent pupillary defect. Here you can see the implementation of this ontology in a frame-based approach through Protege, which we used to develop the structure of the ontology prior to beginning our implementation of the code. The code was designed to operate in two separate formats. The first being a individual analysis case, in which one case of ocular injury was analyzed through the program, and here we put in a schematic case history, and in this implementation, this is extracted to the ontology. We then use forward chaining of the provided injury codes to calculate an ocular trauma score, and we review the accuracy of the output. Here you can see an example of the schematic medical record of eye trauma. This is a hypothetical situation that Paul put together, and at the top you can see the relevant ICD-9 codes, and in the first paragraph you can see the relevant initial visual acuities that we are then feeding into the system in order to calculate the ocular trauma score. This is the implementation shown for the individual use case. The actual implementation is written in processing programming environment, which is sort of a version of Java that's available as freeware. The mapping data that we manually curated for SNOMED, ICD-9, ICD-10, and for the different visual acuity scales are fed into the program through the use of CSV files, which are mined and then parsed. And this mapping is then compared to the injuries that are provided in the case file, and the visual acuity is similarly extracted. Then these values are passed to the ocular trauma calculation system in order to calculate the ocular trauma score and display the output, as well as the outcome probabilities. Here you can see the workflow for the individual case that I just described. The patient is identified as having a direct eye injury. This is entered into the medical record in either ICD-9, ICD-10, US visual acuity, metric visual acuity, and others, as well as SNOMED and the LogMAR visual acuity scale. And then we feed this through the system to calculate the ocular trauma score. The second implementation of the system occurs when the program is run and a folder containing multiple files is selected. This case situation runs through all of the different files and calculates their individual ocular trauma scores and plots them as a scatter plot. The implementation allows mouse over of the scatter plot to get specifics of the individual case, including the outcome probabilities, and it allows a schematic comparison between two protective hypothetical eyewear brands, which is what we're using as a method of evaluating our system performance, is its ability to differentiate between these hypothetical eyewear brands. These schematics were created using a similar injury mechanism, and a series of hypothetical outcomes were generated, and then these were fed into the system to create relevant ocular trauma scores and compare the brands of eyewear. This is just an example of two separate brands of eyewear that we're comparing, calling them brand A and brand B. And here you can see a screenshot of the the calculator in the multiple use case. We call this the aggregate ocular trauma analysis. On the left, you'll see 2 points in red, 2 points in green. Those are points for eyewear brand A and eyewear brand B hypothetical scenarios. And just to demonstrate the capabilities of the system, we also fed it a number of other cases utilizing ICD-9, ICD-10, and SNOMED coding, as well as the US, the 6-meter metric, the LogMAR, and SNOMED visual acuity coding systems. And this particular screenshot is taken with the mouse cursor over the dot that has the little tooltip on it that says Case ID, hypothetical 1 right, eyewear brand A, ocular trauma score 1. Mousing over this will show the specific data for hypothetical 1 right, as well as its outcome probabilities. And on the bottom left, you'll see a protective eyewear comparison, which calculates the brand A average ocular trauma score and the brand B average ocular trauma score. And considering similar mechanism of injury, we deduce here that brand B provided superior eyewear protection. Here you can see a schematic of the multiple ocular trauma comparison program. Here you have 2 separate patients wearing separate types of eyewear being fed through the system. Their medical records are entered in, and in these various different coding systems, the ocular trauma scores are calculated, and then we compare the efficacy of the protective eyewear as a function of ocular trauma. We had a very good time producing this program, developing the ontology, the problem-solving method here, and the implementation of the code. So we're very happy with our results, and we think we've done a pretty nice job here. But there's certainly a lot of room to improve this project, and some ideas for the future would be to deepen the ontology to include injury mechanisms, so that we can relate those injury mechanisms and also injury cases that happen under the same mechanism of injury to one another. And the big ticket item is to apply this to a de-identified data set. In this specific implementation, we had very well formatted data input to the program in the form of CSV files that we populated with eyewear, case ID, visual acuities, and injury codes, and these were fed into the system in order to generate the results that you see. However, in an ideal situation, we would either be able to mine this data from a web source or directly from a patient record and implement the system directly from that data mining approach. So that would be the big next step for us, and we hope to actually go ahead and work on it a little bit more. Thank you very much. Here are just a few credits.